Very good morning to everyone, and thanks for this kind invitation to speak on this interesting topic, which is mitral valve assessment by 3D. My name is Dr. Shrikant Bandyopadhyay. I'm a senior consultant cardiac anesthesiologist at Fortis Hospital, Kolkata. I have no conflict of interest and no disclosures. So why 3D at all? So to start with, 3D isn't just a pretty picture, it is a truer picture. 2D slices, this 2D echo, can miss around 10 to 30% of mitral pathology. The accuracy rate in identifying and diagnosing mitral valve lesions is much higher. And we are done guessing, and we don't want to see slices of the heart. We want to see the entire or the whole valve, like the unfazed view, and come to a simpler yet accurate diagnosis.
So with 2D, we'll be
assuming, imagining, using mental gymnastics, trying to find out which valve and where it is involved. We'll be using two or more of these several views. Could be 5-chamber, 4-chamber, commissural, long axis, and then could be basal short axis and transgastric 2-chamber, and so on. So with the unfazed view, there's very little chance for speculation. It's a simple yet very accurate way of looking at the mitral valve. Now, by convention, if you look at the picture on the right-hand side of the image of the slide, you'll see the anterior, the most structure is the aortic valve, and which is around 12 o'clock position. In the 9 or 10 o'clock position on the left is the left atrial appendage. The AC and PC are the anterior and posterior commissions. The valve is smiling at you, and we can identify the scallops of the posterior mitral leaflets. You can identify the P1, P2, P3 segments of the posterior leaflet and the corresponding portions of the anterior leaflet. In this particular video, what you see is it's very simple to diagnose the P2 flail. There's a flail leaflet with a torn chordae, and there's a perforation at the base of the P2 leaflet. So 3D makes your assessment simple yet more accurate. So 3D modes, how they're different. So there are three basic 3D modes: live 3D, 3D zoom, and full volume. So live 3D is narrow sector, real time, has fairly good frame rates, and it's usually used for quick checks and guiding procedures. 3D zoom is also real time. It focuses on a magnified region of interest like the mitral valve with a fairly high spatial resolution. Full volume is ECG gated, stitches multiple beats for a bigger pyramid, and can cause stitch artifacts, especially in presence of irregular rhythms, and isn't truly live. So there are many ways to obtain the 3D data set and many ways to optimize and manipulate them. So this is the 3D home of the Philips Affinity 70 machine, and you can see there are several buttons, of which I think the mitral valve navigation, multi-view, multi-slice, eye-crop are the most relevant buttons. I'll come to that as the talk progresses. So what are the ways to manipulate the 3D data set that you obtain by live 3D or zoom or full volume? So there are many ways of manipulating it. You can simply not use specialized software. You can simply optimize, crop, use unfazed view, use the angle view to look at the mitral valve, or you can use specialized software like the mitral valve navigation, eye crop, multi-view, multi-slice, and even mitral valve models that you can derive from the data set. So 3D versus 2D, the extra dimension is depth or elevation plane. So if you understand the elevation plane and how to play with it, it makes all the difference. So let's quickly understand the plane of elevation and how we can play with it and achieve our daily goals in the operation theater. So let's say we want to obtain the unfazed view. The unfazed view is usually obtained by the 3D zoom, but you can actually use any of these three different modes to obtain the unfazed view. So let's look at this 4-chamber. Basically, start with the 4-chamber view, and you hit the live 3D button. You can see a narrow sector live 3D image. The mitral valve is not completely seen. So what you can do is simply increase the lateral width initially, and then you can increase the elevation plane until you see the entire mitral valve. Then you can tilt it towards you, and if you rotate from this position, if the aortic valve is taken using the rotate Z button anteriorly, you will get what is the unfazed view. So it's very easy to actually obtain an unfazed view even with live 3D. So the conventional way is, of course, with 3D zoom. So what you need is two orthogonal planes. In this case, we're using a 4-chamber and a 2-chamber, and you ensure that using this elevation position, elevation width buttons, you can actually place the mitral valve within the zoom box and then hit the zoom 3D zoom button But what you get is pretty confusing for the beginners. So you get a truncated cone-like picture. What you need to do is reduce the gain and look at the structure. In this case, you can see the aortic valve looking at you. So you need to rotate the entire data set and the aortic valve anteriorly. So, and then you can use the trackball to tilt the image. So the mitral valve now looks at you. That is the unfazed view. You can use the zoom button to sort of get the picture closer to you. You can see in more detail, and you can tilt the image using the trackball to look at other structures like the left atrial appendage on the left, and so on. So this is how to play with the sort of 3D software and the buttons to achieve your unfazed view. So even from this is a full volume data set, and you can use the eye crop to obtain the unfazed view from the full volume mode. In this case, the valve is tilted and the aortic valve is on the side. So you can sort of use a 3D the rotate Z button to get it into the unfazed view. So where does 3DT have an edge? It identifies mitral valve pathology more accurately. The mechanism, location, severity of MR is more accurately it's possible to accurately identify the mechanism, location, severity of MR using 3D. 3D vena contracta area is more reliable than a 2D vena contracta, and quantification of mitral valve area for stenotic lesions is more accurate with 3D, and live 3D or zoom modes are excellent for procedural guidance. Why does 3D have an edge? And also, 3D is significantly more accurate in identifying lesions like prolapse, flail, cleft, etc. compared to 2D. Now let's quickly go to different cases and try to identify how 2D and 3D are they're complementary, but 3D is better in many ways over just 2D alone. So this is a case where we have a patient undergoing CABG. We have a fairly big heart with a dilated LV and it's around 35 to 40% LVEF. The mitral valve looks normal. Cooptation is not bad, but there's the central MR. So what is the problem with the mitral valve? So the valve is normal. Only the depth of cooptation in the center, especially in this 3D zoom image, you can see the depth of cooptation in the center is less, and exactly that's the point where you have a functional central MR. And you can notice on the 2D, the cooptation length is very short. So this is an example of a functional MR, and this is because of the annular dilatation. And now we're going on to the next case with a 29-year-old lady with progressively increasing breathlessness and palpitations over the years. So what is the problem? You can see a large ASD, in this case a ostium primum ASD. The cooptation of both the tricuspid and the mitral valve on the 2D seems fine, but there's a moderate or maybe a moderate to severe MR. On the 3D zoom, you can see deep cleft in the A2 leaflet, and on the color Doppler you can see there's a moderate to severe MR originating from the cleft. So this is a patient with a ostium primum defect with a mitral cleft. So next patient, 56-year-old lady from Bhutan with history of fever and chills 2 months back, associated with the stroke causing left arm weakness. So what is the cause? On the 2D you can see there's a channel-like opening right in the middle of the A2 leaflet. There's a moderate to severe MR, and there's a vegetation hanging from the A2 leaflet, and you can see the comparative 2D versus the color Doppler. But the unfazed view gives away the diagnosis. So there's a funnel-shaped deformity which is related to the vegetation, and there's a perforation in the deformed A2 leaflet. And we saw the surgical sort of picture and compared the surgical picture with the 3D images, and they're exactly similar. So you can basically predict with the 3D, you can be very accurate. Now, excessive leaflet motion. It's a 58-year-old gentleman with long-standing history of palpitations and breathlessness, which has been worsening over the last few years. So what is the diagnosis? So really baggy, a huge valve with multiple, on the live 3D you can see there are multiple clefts and indentations, and a lot of the leaflets are prolapsing, and there are multiple jets, at least two big, huge jets. And if you compare normal versus fibroelastic deficiency versus Barlow's disease, what do you think this particular patient has? This is a classic example of a Barlow's disease where you have excessive leaflet motion, the prolapsing, all the leaflets are prolapsing. So basically, except one. So you can see the A1, A2, A3, and the P1, P2 are prolapsing. The P3 is the only one that's spared. There's a severe MR. There are multiple jets. So I decided to sort of calculate the severity of MR. So what is the best way? So benefit of 3D vena contractor area over 2D based echocardiographic methods in quantification of functional mitral valve regurgitation. So 3D vena contractor area overcomes the geometric assumption of 2D methods, especially in asymmetric Christian-shaped or multiple leaking jets. So this is how you can probably, the best way to calculate the vena contractor area is either of these various possibilities, either MVN, multi-view, multi-slice. The easiest is, in my practice, I use multi-view, and this is how it's done. So basically, you are aligning the red. Once you hit the multi-view button on a 3D data set with color, so you're aligning the red, the green, lines along the MR, and then you get the blue line across the narrowest point of the jet, and in the cross section, you can freeze the image. And mid-systole, I can actually calculate the mitral valve area. In this case, the vena contractor area. In this case, it was 0.67 centimeter square, which is a severe MR. So you can either use the multi-view or on the right side, the multi-slice to calculate the vena contractor, 3D vena contractor area. So this is again a 54-year-old male with severe MR. What is the diagnosis? So excessive leaflet motion, severe MR, and you can see leaflet is flail, and the 3D gives away the diagnosis very nicely. It's a very damaged valve with multiple, torn, ruptured chordae, and on the 3D zoom, especially the angle view, you can see there's a huge coaptation gap. So 3D basically gives you a very, very clear picture of what exactly the pathology is. There's a classic rheumatic mitral stenosis where you can see the fish mouth appearance with commissural fusion, rolled and thickened out leaflets. On the 2D, you can see the fixed PML and the hockey stick appearance in diastole of the mitral leaflet. So this is both MS and MR. Another example, you can have a P2 leaflet which is fixed and the prolapsing A2 leaflet with a severe eccentric posteriorly directed MR. And then on the 3D zoom, you can see the prolapsing, entire prolapsing anterior leaflet, and there's a coaptation gap as well. And when you use this data set, the 3D zoom data set, you can actually calculate the 3D mitral valve area can be calculated using the same software, which is multi-view. You can use the red and the green lines to align along the open mitral valve. You can calculate in the mid diastole. You can calculate the mitral valve area in the third box on the left hand. So basically, MVA by 3D planimetry is the gold standard. 2D can be overestimated by 20 to 40% in calcified valves. So what is the etiology of MR in this particular case? Any thoughts? Severe MR, and there's a definite tear in the leaflet, and there's a severe MR. So live 3D images, 3D zoom, very similar, and this is a surgically explanted valve, and it shows exactly what the 3D image shows. So this was basically a 22-year-old female with rheumatic heart disease, severe mitral stenosis, with attempted balloon mitral valvulotomy by interventional cardiologist, followed by a rupture of the AML through A2, causing acute severe MR. It was referred to us for MVR. I don't have 3D images of ischemic MR with teeth ring of the leaflets, so I'll just leave this part and then go forward. So the next topic is the significance of 3D in identifying extent of associated disease. What is associated disease in this particular case? Any idea about this case? So I can simply see there's a P2 leaflet flail and a severe eccentric MR which is directed anteriorly. But what else is very, very important, which is shown on 3D, not on 2D? So there's a severe annular calcification. You can see chunks of stone, like chunks of cement-like thing, hardened over the years in the posterior annulus, and the patient received a bileaflet mechanical valve, and immediately post CPB there was a significant paravalvular leak, and the 3D zoom image showed an extensive, the picture was much more accentuated, much more clearer on 3D zoom with color. You can see there's an extensive paravalvular leak on the lateral and anterior aspect of the bileaflet valve, So it had to be something had to be done with it. The surgeon looked into it, and he basically he had sutured the LA wall with the swing ring, and eventually that helped, and the jet was reduced to much less compared to the previous one. So you can compare the images. The first image immediately coming after bypass, then the severe paravalvular leak, then the surgeon sutures the LA wall with the swing ring, and eventually the jet goes much smaller. So 3D is superior to 2D in identifying the presence, degree, and extent of mitral annular calcification. Another case, 59-year-old lady with CKD on maintenance hemodialysis posted for mitral valve replacement for moderate MSMR with old calcified vegetation suspected on TTE. So what do you think this is? On the 2D, you can see chunks of calcium, and the AML is relatively spare. You can see MS and MR, not that significant. It's probably maybe moderate, not severe for sure. But the PML is fixed. On the 3D, you can make out the huge chunks of calcium sitting in the posterior mitral annulus. And this is the manipulated live 3D, and the zoom images, very heavy calcification. This is the only case where the surgeon in the last 20 years, I've never seen mitral valve get cancelled. The surgeon was very skeptical in this case, opened up and said that the calcification was going deep down, even in the posterior wall of the ventricle. So he refused to sort of operate, thinking that there'll be a rupture of the left atrium if he does that. So the lesson is 3DT does a fantastic job in identifying the severity and extent of mitral annular calcification. Now, the calculations like this and deriving models of mitral valve like this is very much possible, but in my practice, I don't have much clinical significance of things like this. So I have one more case, I think the amount of time just passed by. So just to sort of summarize, where does 3DT have an edge? So 3D datasets are easy to obtain, optimize, and analyze, and it identifies mitral valve pathology accurately, correctly identifies mechanism, location, and severity of MR. MR conductor area is more accurate in quantifying severity of regurgitation compared to 2D. Accurate quantification of MVF for stenotic lesions is possible with 3D, and it's a gold standard. Live 3D or zoom modes are excellent for procedural guidance. Thank you so much. Some of the videos that I've shown it can be seen in my website, which is my same name with MD and FA. So if you add to my name, you'll get the YouTube channel. Thank you.